want to thank everybody for coming, and I'm going to hand this over to my sister, Marcia Edelstein Herman, class of 1978. Marcia.
Okay. So good evening. I'm Marcia Edelstein Herman, MD, class of 1978. My brother David and I want to welcome you to the second annual Alan and Sybil Edelstein Lecture on Professionalism and Ethics in Medicine. This lectureship was initially envisioned by our late father, Alan Edelstein, who was a graduate of the BU School of Law and the BU School of Management. During his career as a certified public accountant and a lawyer, he served as head of the Alumni Council at the School of Management and on various committees at the law school. After retiring, he served on the Board of Visitors at the School of Medicine for 25 years. David and I set up this lectureship in memory of our father and in honor of our mother, Sybil, who turned 96 just this week. So we wish her a happy birthday. As we thought about topics for this year's lecture, what stood out was how the COVID crisis intensified the challenges of doctor-patient ethics, particularly in areas such as autonomy, equity, privacy, and trust. It was Alan's wish, along with ours, that discussion of professionalism and ethics be given more prominence in medical education, and that it would lead to continuing improvements in the delivery of healthcare. Better care, more equity, and greater doctor and patient satisfaction with the process. We're delighted to have you join us for this very timely session this evening. And now, before I turn it over to Dr. Grillone and Grunfast, please look at the upcoming slide and mute your microphones during the speaking program. Thank you, and on with the program.
Recorded.
Hi, everyone. For those of you who don't know me, I'm Greg Grillone. I'm the chair of otolaryngology here at the Chobanian Abedisian School of Medicine. We're very pleased to be hosting this program, and I just want to welcome everyone, as Marcia mentioned, to the second Alan and Sybil Edelstein Lecture on Professionalism. I especially want to thank both David and Marcia for their generous support of this lectureship. And I also want to thank David and Ken Grunfast, who's going to speak in a moment, along with the BUSM Development Office for really doing all of the heavy lifting to organize this event. I'm so pleased to see so many familiar faces. Dave Edelstein was one of my mentors at Mount Sinai, and I see Frank Lucente, who is one of my mentors as well. So welcome, Frank. And I just want to say, I looked at the program. It's a wonderful, wonderful program with an excellent panel, but also a very full program. So without further delay, I'm going to turn things over to Ken.
Thank you, Greg. And most of all, thank you to the Edelstein family, for Alan, who's no longer with us, for Sybil, who just turned 96, and Marcia and David, thank you for supporting this and for your generosity. I have to say that Alan, who was a World War II veteran and unending, unwavering, loyal graduate of Boston University, both the law school and the business school, just very, very loyal. He embodies what it means to be loyal. And I am very much looking forward to hearing from the speakers this evening. All of us lived through the COVID pandemic. Honestly, before there was a vaccine, I was afraid I was going to die. I was afraid to see patients. I will forever be in reverence of this kind of people that the speakers are this evening and for the decisions that they made. What an unbelievable challenge and what an unbelievable performance. So I'm eager to hear from these people.
Well, thank you very much. I'll take over as moderator, and I'm actually one of the panelists, and it's a really wonderful lineup. I will talk about each person, some of their background before they speak. So here's my background. I was class of 1980 and been the director at Northwell Manhattan Eye and Ear for 25 years. But what really drove me to this subject was I was the interim chair at Lenox Hill for the 2.5 years of COVID. They asked me, could I come do it for a few months, and then proceeded to have probably the most challenging time of my career. Fortunately, I'd been medical director at Meath sometime in the past, so I'd dealt with some smaller issues, but nothing quite challenges us as the COVID crisis. If you go back to the New York Times, there were articles on each one of these. The biggest one was on resources for frontline workers and for patients, and we're going to hear a variety of people talk about that. Clinical decision-making, which I will chat a little bit about, and how that personally affected me and my department and my patients. All kinds of issues on patient privacy and individual rights, which we will discuss, justice and equity, and public health responses. Now, ultimately, the question always is, how do you make ethical decisions? I mean, in my family, it was easy. My father had a pretty well-developed ethical compass. So we are who we are and what our village is, but we also bring to it our religious backgrounds and whatever our moral standards. But there has to be a more coordinated view, not just that this is what my family would do. If Dean Antman is on, I'll tell you that one of the courses that people think was not an essential course my first year was in social and community medicine. And I will tell you, during COVID, I thought of it quite often. And one of the books I still have on my shelf was a book by Victor Fuchs, which was called Who Shall Live? And people who don't think we're making ethical decisions every day, we do. But during COVID, it really became a very important book. And I was glad that I had read it as a first-year med student. Obviously, we are taught how to do things during residency and fellowship, and we hope that we have good mentors. I think we mentioned lots of mentors on this call. We have a hospital ethics committee. We have a co-chair of the ethics committee speaking. And then, I was chair of the board of governors for my academy. In our leadership meetings, we talk about ethics. Now, just to set a little bit of the format, ultimately on the left, and other people will chat in more detail, is standard ethical care. Autonomy, you focus on the patient. You have to do what benefits the patient. You do no harm, and you have to have some type of view for social justice. But other people, and I gave 2 references here, have talked about that during crisis, ethical care changes a little bit, that the solidarity is with the group, and it's relational autonomy. It's with not just one patient, but all your patients and many patients. And the patients you're not treating, how do you deal with the issues? The duty of care, I will let other people chat about it. We talk about equity, but I'll say one thing in New York, the Helsinki principles in Nuremberg is there are some groups that we have to basically take care of. One of them are prisoners, and New York did a horrible job. There were conversations in some of our newspapers about why do we give them masks? The answer is because they are a group that is dependent on us. The fact that 85% of them got COVID was an embarrassment, but we can talk more about that later. There has to be some mutual understanding. And again, there's a variety of reciprocity. It's not just a one-way ethical program. So just 2 quick issues for me, just to tee them up, which was how to make assignments. And I had 152 people in my department. And the issue is, are all doctors or staff to be treated equally? Well, usually the answer is yes. And do you take into consideration, most people I just say, keep your family problems at home. If you have an issue, come talk to me privately. But what you do at work is what you do at work. And ultimately with COVID, this was turned on its head. We also had a few doctors that refused to care for patients. They needed a little tender loving care from me because the issue is it is our duty. When I was training, we had early HIV. We didn't know what it was. And that affected doctors and surgeons as much as it did patients. And do full-time faculty have a different obligation? Think about it. So my thought process on this, just to tee it up, was first I said, who's healthy? And if you're not healthy, if you don't mind telling me why not, so I will change your assignments. Do you have family obligations? Some people had very elderly people living with them. Or one of my doctors had a newborn early on. I wanted that baby to still have a father. So the answer is I changed a little bit of the protocols initially. If somebody has unique talents, they needed to use it. So you can see that basically there were some strategies that changed. And then the last issue that I'm going to chat about very briefly is who did we do tracheotomies on? And a tracheotomy is a hole put in the neck. If you were lucky to be ventilated, and you were ventilated for a period of time, then ultimately at some point you needed to not be intubated in order to protect your larynx, your voice box, and your trachea. And the tradition was to do it at 10 days. Well, for every otolaryngologist here, the question was, how did we pick 10 days? And so ultimately, we actually extended it beyond 10 days. We tried to do it somewhere between 14 and 20 days. But if somebody was too sick at various times, we went as long as 28 days. And we used slightly different guidelines. Different institutions in New York used, some used percutaneous trachs, which is they made a little pinhole and very quickly put it in. We as a group didn't think that that was good for our doctors, respiratory therapists and others, and anesthesiologists. So we actually did bedside or operating room trachs. And how did we make these decisions? So there was a group of 8 of us, both men and women, and from different backgrounds. We were all doing the trachs. And so we came up with a variety of protocols with the ICU and the infectious disease people. And we went over it every single day. And as the data changed, some of our viewpoints changed. Probably the toughest thing was accepting problems. Did we make mistakes? Sure, we did. And then there were issues, which is, we didn't want to have bias. Lennox-Hill is one of the 5 big hospitals in the city. We early on decided that if we were allowed to go to 120 or 140% of capacity, that we would do it. And so probably most of the year we had more patients from outside of Manhattan and from our catchment area than we did within it. We tried to involve families. Families were just as freaked out. And we did publish an early paper there. So this tees up some of the issues on ethics. And I'm going to move now to Ravin Davidoff, who's the executive medical director. He actually was the dean of clinical affairs and the chief medical officer during COVID. So I'm happy to see he didn't turn completely white. He's professor of medicine. And you see his background. He's obviously a wonderful teacher. So Ravin.
Thank you very much. It's really a pleasure to be here. And I'm just going to set my timer here because I've been told I have 8 minutes. So there's 2 reasons I'm going fast with this. One is David has told me I need to be going fast. But the other is I want you to get a sense of the pressure and the pace at which we were working. So when you look at this on this slide, you'll see that this is March 26th. 2020. So we had an ethics committee. Michael Young is going to talk a little bit about this. We were thinking through these 3 core tenets, and we're thinking in the theoretical situation about how do we balance these different things about the individual versus societal needs. Next slide, please. And as we went through this, you can see that this is the shift from focusing on the individual autonomy that David just talked to of patients to the overall public good, and how do we move to maximizing survival at the community and societal level. This is a dramatic change for individual physicians who are so committed to taking care of every person in front of them. And obviously we integrate the family's input, but our goal always is to do what's best for that individual. Next slide. And this was when really we became the canary in the mine, we being Boston Medical Center. So that I was just referring to was late March. And here you see by the 5th of April, we had this exponential increase in the number of patients. And on that Sunday, we sat in our war room, and there were a good number of us in our war room that we created, and we were overloaded. And the others around town were not yet. I got on the phone and called to my colleagues across town, a number of us did, and we were able to get 9 ICU patients transferred that Sunday. But it was really the wake-up call for all of us in the city at that point. BUMC was being overwhelmed by the demand, and most others were sitting back and watching, and there was no state coordination or integration of our needs. But that woke us all up, that we could not cope anymore. Next slide, please. And so that Sunday, Betsy Gaydon, the chief nursing officer, and I huddled together. We created a video that Sunday night. And over the next 3 days, I think these were the most challenging times of my career. And it's now sort of 45 years I've been practicing as a physician. When I met with 12 departments, large groups of people across the organization to explain what crisis standards of care were and where we were going, and explaining to people the incredible difficulty and pain that we were likely to go through, and that we were ultimately going to do the best that we could, but we didn't know what that meant. And the key was that we, BMC, an organization and university hospital, had been around for over 160 years, and we were going to be guided by those ethical values and the patients we've always served as a safety net institution. And, you know, I left in tears from many of those meetings. There was just a documentary that was created that is showing at the moment, and which, you know, unfortunately caught me crying as I reflected on this, and that's in the documentary. Next slide. But that was the pain we were going through as we dealt with this. And here you can see on April 14th from a Boston Globe article, down on the bottom, BMC at 44% of our patients at that time were patients with COVID. And remember, at this time also, there was the huge uncertainty because one couldn't get testing. We were sending these tests across country, and they sometimes never came back to us what the result as they went out to labs in California and Utah. And at the peak of the surge here, we had 70% of our beds at BMC were occupied by COVID patients. Next slide. And here to amplify the inequities that this exposed, and this, I'm bringing this up because of the importance of considering all aspects, and it will lead into some of what Michael Young will talk about, how we contributed to the thinking at our local level and at the state. Arrayed on the left-hand side in the dark blue is Black African-American patients, and in the pale blue color, those of Hispanic or Latinx origin. And our prior year had 59% of patients who were admitted who were of that ilk. And then as you look down the third from the bottom, 76% of patients were Black or Hispanic. And then when you look over on the right side, the dramatic impact of homelessness, doubling up from 9% to 17% of COVID positive patients admitted. Next slide. And this is what Thea James, you know, one of our real leaders in inequity and racial inequities, talked about, stuff that I think we're familiar, but I'm bringing it here because it's so important as we think about equity. The disproportionate impact of the virus was a predictable outcome. All the long entrenched racial and social inequities that primed communities of color and low-income residents for a higher risk of exposure, an undue burden of disease, death, and the economic deprivation. Enormous issues for us to struggle with as an organization and those who we serve. Next slide. And here, just the things that we faced, looking at the first slide over on the top, our innocence and ignorance as we faced, as we went in. And then all the PPE that you can see for people going in, the fact that MIT turned around and created masks for us in a week because we thought that was critical, and they stood up and developed them and brought us to our bedside. The N95 issue, and I'll show this in a moment. How do we recycle these? There just weren't enough. How do we treat patients moving into the rooms, using audiovisual? The inequities on the patients that we serve, the inability for their families to see them, communicating through iPads, the fear of going into the room, the unknown. I too was in the HIV epidemic with AIDS and remember those days well. This was a very similar approach that we struggled with. And down on the bottom left, the ORs, which are positive pressure environments, very adverse for patients with COVID. Next slide. And then here, just one point, it won't be easy for you to see, but we had 6 days of small N95s. I can't use a pointer, but over under the yellow areas, we had 6 days. How do we decide who gets the N95s when you're down to that limitation? And this is the degree of planning that we were doing day in and day out. Next slide. And eventually we decided to optimize to the ED. How did we do that? We shared the information broadly. We decided that was the highest risk group with those with the greatest uncertainty. And that's where we allocated our short supply, small N95s and others. The ventilator issue that David talked to was really critical. Here we were trying to project on the 6th of April, and you can see the slope of those lines. Depending on how many patients needed to be intubated, we would very quickly exceed our capacity if we were on the red line. And we anticipated that we would be along that red line. Next slide, please. And here, looking at all the potential sources of ventilators that we had, we knew then those that served the ICU patients. And then we said, how are we going to bring the anesthesia machines out of the ORs, which don't interface fully with the electronic equipment? Well, how do we use the transport ventilators and the non-invasive vents? Could we use things like CPAP? And decided that wasn't a good idea to use because of the risk of spreading the virus. I got on the phone to the VA, to our colleagues there, and that afternoon, they shipped over ventilators for us. But soon thereafter, called back and said, we need them back. We looked at the option of potentially putting 2 patients on a ventilator. The incredible angst that we went through and the speed of decision-making and the ethical challenges we had day in and day out were just frightening and enormous. But, as I come out of this, I think about the enormous contributions we made and how carefully we did this and as best we could. And for me, for sure, the communication was such a critical issue. Next slide. Here was how we did it in the ED. It sounded similar to David. We took the decision away from the primary teams that we would have a pandemic triage response team who would look and potentially advise going up that no arrowhead to where there would be supportive care only. But that would be done by a triage response team and not the first line physicians. Unbelievably challenging times for us to even think about this concept. But we had this down and we had a plan in place. And thank God, we never had to deliver on that approach. Next slide. The last 2 slides I'll show, which were another ethical challenge coming out of this. When COVID vaccines became available, who gets the vaccine first? How did we prioritize on the healthcare workers? We clearly had guidelines. Next slide. And along the top row, you'll see there are many things here in small print. But we very publicly talked about how we were making the decisions about which employees would be in the first wave on December 22nd that would receive the vaccine and how we would roll that out. And then we went into our second wave, and then we went into the third wave, triaging along the way as best we could with every principle that we thought was important for us as an institution, and then to share that information widely. This was not easy as people stood in line and others tried to get in and said, I should be there. We talked it through as best we could, but surely this was the most challenging period of my life, and I'm sure of many of our lives. But I look back on it with sort of a sense of great gratitude, a great thanks to whomever one believes in as a higher power, that we came through this in a way that I feel so proud of what we delivered, despite the many, many challenges. So I feel privileged to be here talking to you all. Thank you for this opportunity. And, my pace was hopefully consistent with my time allocation, but more important was intended to give you a sense also of the speed with which we were moving. Thank you, David.
Thank you, Ravin. Obviously, the Boston Medical Center and the med school is lucky to have you. Our next speaker is Michael Young, who serves as the medical director of the medical ICU, was co-chair of the critical care executive committee that obviously was a core part of the groups that was working with Dr. David off. He happens to be the co-chair of the ethics committee, and you can see his professorships, and obviously was a member of the ICU directors in the Boston area and set some of our standards for the medical center. Michael?
Hi, good evening, everyone, and thank you, Marcia and David, for hosting this, and to your parents' wisdom for establishing this event. So let's see if you could go to the next one. Yeah, great. I think it's a big topic tonight. The challenges of the ethical challenges involving COVID, and so what I thought I'd do is spend the time to narrow the scope a little bit of my comments to how I thought about the very abstracted ideas of ethics and how they can be and were employed during the pandemic as tools, actual tools, and not just abstract concepts towards as essentially a guide towards developing processes that ended up reflecting our core values and which we could then be confident in employing. To do that, I'd like to just take do a brief review of key ethical principles relevant to healthcare crises or disasters. And none of this will be particularly earth-shattering or new to any of you. But what I and others have found is that it is helpful literally putting this down and saying these things as a reference or point of departure, because as you all know, in the moment of a medical crisis, hitting on all the basics can sometimes escape people. And for that reason, we rely on checklists or other tools to remind us. In that spirit, I wanted to present these ethical norms that are to some extent embedded in many of the very codes we've pledged to, or not the least of which is our friend, the Hippocratic Oath. So essentially divided into two groups. And this is, and you can see some references here, core ethical tenets, which we basically held as values and we would employ in thinking about the processes, and then key process elements, which are essentially guiding ideas about how a process should be employed. For the key ethical tenets, the duty to provide care, which we've talked a lot about, and is essentially the fundamental obligation to provide care for all people and to help them in harm reduction and benefit promotion. Fairness, which was a big issue that we kind of thought about a lot and that Raven alluded to, because at BUMC, we treat some of the most vulnerable, and our focus is on making sure that we treat them as equal as we treat anyone else when they come to our door. But a step beyond that is to think about when they arrive to our door, what do they come with and what do we have to be considerate of? Our duty to restored resources was an important consideration, and particularly during these times on the topic of ventilators. But that wasn't the only thing, and I would like to emphasize that although there was a lot of discussion about ventilators, there were a lot of other resources, as Raven alluded to, like PPE, that were truly scarce, and that is where we really needed to focus our ethical deliberations on. In terms of the process elements, I think these are actually some of the most critical things to keep coming back to, and it seems simple, but you'll find that, and I found, and I think many of us found, that when we went ahead and like kind of set a plan and set an algorithm, that things like transparency, accountability for communicating that algorithm, and being consistent about letting everybody know was a major challenge. Communication, as Raven knows well, was one of the hardest things to kind of employ in a consistent way, so that you touched on all the people that needed to know, but you didn't alarm everyone and hamstring them. And the idea of accountability is critical to any process that we're going to employ in these crises, because we want to be sure that we can speak to our patients and say that this is well thought out, and we can tell them that it is based in some reason, and then importantly, it's consistently being applied. And so those are kind of some underlying ideas that I'm next going to go through about how this actually worked in the ICU, among the hospitals in Boston, and also at the state level, kind of as I observed it. So although this is about challenges, what I thought would be important is to talk about how these ethical principles were actually being employed and how they helped us decide on what to do. In the ICU, one of the first things we did was think about how we had to provide care to all these people and what that would take. And so one of the things that we focused on from the outset early, and I think it's actually the end of February when we saw what was coming down the pike, was to think about, given the number of physicians and nurses we have, how can we think about delivering critical care for those patients? And although there are a lot of critical care docs, they're not all necessarily focus on delivering medical ICU type of care. And so we had to think about how we were going to educate and also support other intensivists who might be in surgery, who might be in neurocritical care, to help us deliver that. And so we then really focus a lot on our duty to plan. And if you can go to the next slide, you can see how we actually set up this whole grid ahead of time to think about what we needed to do in terms of surging. And we did surge, and we were planning well ahead for the potential capacity to staff 145 beds, ICU beds, that is. And what you'll see here is all the number of surge teams that we kind of created and crafted out of intensivists. And we even thought at the very end, if we needed to surge further, how we might employ essentially intensivist extenders using multidisciplinary groups. We ended, fortunately, we only got to step number 6, where we had to surge another MICU team beyond all the surgical and neurocritical care intensivists. But this is, I think, a great example of how we felt the obligation to plan and plan well in a realistic way. Next slide, please. And then in terms of other ethical principles that we employed, so the transparency and accountability, I think for ourselves, and I think, a lot of what I'm going to talk to you about is the staff, because I was really at the center of doing a lot of staff planning and working with staff and seeing how very, very strained and taxing this whole event was. And so we felt it was extremely important to be transparent with our staff, tell them what our plan was, literally on a daily basis, on what the staffing plan was for that day. And as much as that seemed almost like overkill, I think that it really served a purpose in supporting the staff and supporting morale, most important. One of the things that came up was the idea that some of these patients who were engaged would actually not benefit from CPR, but we thought about this a lot, and we really settled on the idea of CPR not being indicated was not a policy that we could employ. And so we treated and continued throughout all our ICU care to employ our standard practice of talking to the family and talking to the surrogates and asking them what they want to do, incorporating their values. Among the hospitals in Boston, I think, and I'm happy to say that we had a very coordinated effort. I think that probably the cynic in any of us might think, it's a very competitive town. How could you work together? But I was actually very struck by how, when we were asked to all come together and meet on a daily basis, we had representatives from each hospital come, ICU leaders, and everybody talked about what they were doing, what they needed, and what they could do. And how we shared amongst the hospitals was very substantive. At the state level, I think the other way that we saw this employed was the way we looked at crisis standards of care. And so just over the 3 different iterations of crisis standard of care, there was a lot of changes that reflected the ethical principles of transparency and accountability, in that they asked for feedback, and that feedback progressively improved and removed certain things that were felt to bias against people with disabilities and or comorbidities that they had suffered from inequities. So among the outstanding challenges, and here's the step, and I'll try to finish this up quickly. I think that what still remains, and what I'm struck by, is that at all points of care, it was very difficult to get community and patient input, for probably obvious reasons to everyone. But nevertheless, that really is one area where we kind of fell short on, because it was really difficult to do, and there were no established vehicles for that. Although crisis standards were defined, they were never invoked. And the key thing there is that there was so much focus on ventilators that all the other things like PPE and a number of other things like staffing were less attended to. And that's probably where we needed to put our attention. And then in terms of the duty to plan responsiveness, despite all our experience, even with the second surge, I think when a lot of our ICU doctors felt like we knew that there were going to be bed shortages, the overall system was very slow to respond and plan for that. And I think that was a key thing and remains a key thing. I can go to the next slide, and just so I can wrap up. I think one of the things that in working with other ethical thought leaders we've thought about is really, as I've hopefully exemplified here, having some kind of tool to keep these things on the front page of any kind of planning document or planning body is key to think through it. And our leaders need to have these types of planning tools before them, so that they can keep asking them, are we doing these? Are we thinking about transparency? Are we being accountable? And I think I'm going to end there. And I just put this up here because there were a lot of people who worked on this, and I just wanted to have their names up here. Thank you.
Thank you, Michael. I'm going to move to Jessica Pesegna. Dr. Pesegna, she's the head of speech and language pathology and the director at the Voice Center at BUMC. She's associate professor. I think she's also a professor at the Sargent College. And Jessica?
Thank you so much for this opportunity to be part of this distinguished panel. I hope to highlight my perspective as the director of the speech language pathology team. For those who are not familiar, we provide services across the spectrum of medical care, from the intensive care units to clinic visits. We treat patients who have trouble speaking, swallowing, and have had surgeries like total laryngectomies, or tracheostomy tube. So today I'll review 4 difficult aspects I faced while leading a speech pathology team during the COVID pandemic. Next slide, please. And next slide, please. Number 1, the ethics of telehealth. So it turns out a lot of what we do exposes the clinician to COVID because COVID is airborne and we spend a lot of time very close to patients, particularly close to their mouths and throats. Next slide, please. So when the pandemic hit, it was necessary to review all of our services, and turns out all of them were aerosolizing. So we quickly transitioned the majority of our services to telehealth. Next slide, please. One of the ethical dilemmas I encountered was when clinic was opened only for a few select urgent visits. So we used color coding system where speech pathologists would review the records of each scheduled patient and code it based on their perceived urgency. The picture here shows a screenshot from a staff email that I sent describing how to color code each patient. So red, for example, meant urgent and staff were to call to confirm the in-person clinic appointment. Green meant call the patient, cancel the upcoming appointment, and reschedule for telehealth to try to manage over the phone. And looking back, green patients were the most at risk for being lost to follow-up or developing more severe disease. Next slide, please. The pitfalls of telehealth are many, such as inability to connect. So many of our patients are elderly and they weren't able to figure out the texting system or video connection, and some of our patients don't have mobile phones. Some patients needed speech therapy, and if they've had neurological problems or surgeries in their mouth, they weren't able to speak clearly enough over the phone to be understood. Some of the most troublesome telehealth conversations were when patients had been at home so long that their symptoms had become very severe. These appointments had been rescheduled so many times that it was months before they were seen. For example, we were managing over telehealth what sounded to be chronic cough or trouble swallowing, but it actually ended up being a large tumor that would have otherwise been noticed with more regular in-person visits. Next slide, please. My second point is the ethics of inpatient triaging. So half of my team works daily in the ICUs carrying out swallowing evaluations. And in the beginning of the pandemic, very few medical providers would actually go in and out of COVID positive rooms, and that was to limit exposure and to preserve PPE. And we were really stuck because some nurses didn't want to perform the swallowing screening tasks, and there were medical teams who didn't want to place feeding tubes. And so listed here are actual phrases from consult notes demonstrating the pressure from consulting teams in the higher risk situations, such as to conserve PPE will hold meds for swallow eval. Next slide, please. So keep in mind that our team had also faced furloughs, and 75% of our staff were carrying out backlog of telehealth at home. So we were operating with only 4 to 5 speech pathologists in the hospital. So we developed a triage list in order to see the 60 to 70 patients on our daily caseload. And the ethics of creating a list of who would be seen was very much a practice of values and principles, the greater good versus individual treatment. So for example, the hospital was in desperate need of beds, and some patients needed us to see them for a swallowing evaluation to be discharged. And so those patients would be triaged higher than someone else. And this felt counterintuitive because it didn't follow medical acuity, but in theory, it was freeing up beds for newer patients. The system wasn't perfect. Some patients needed therapy, but rehabs were closed and not accepting more patients. So patients would be discharged home and set up for teletherapy. And then they would be stuck in this teletherapy loop of inability to connect and rescheduled again until the problem was worse and they represented to the ED. Next slide, please. In triaging patients, we also had to manage time, which forced more tough choices. Near the top of our triage list was patients on whom we could perform a quick eval. At one point, because our endoscopic evaluations were so lengthy and aerosolizing, I wrote to our team that we were to avoid this procedure at all costs. And in reflection, this was when I had made the mental shift to choose the greater good and protect our staff from exposure over treating medically complex patients. Next slide, please. My third point is the process of decision-making for patients. Who gets to eat? So when we observe an unsafe swallow, we're faced with making a recommendation. The obvious recommendation is NPO, nothing by mouth. This is the safest recommendation. That's the medical perspective, and it embodies the value of physical safety. However, the majority of patients don't share this value. Instead, they choose their personal value of comfort for eating and drinking, quenching thirst. So can a patient make their own decision and refuse medical recommendations if they express the understanding of risk? Generally, yes. But what if it's at someone else's cost? So I just want to highlight one example. We had a post-extubated COVID patient in the ICU who was able to demonstrate understanding of the risk of known aspiration, and he was okay with taking that risk. He began to eat and drink and developed worsening shortness of breath, acute respiratory failure, and was re-intubated, taking up a ventilator that was needed for someone else. So should we have mandated NPO for him, or is self-governance always the answer, perhaps at the cost of harm to others? Next slide, please. Next slide, please. My final point is the ethics surrounding staff safety, which was the most emotionally challenging for me, to lead my team and not know if they would be okay. I have mentioned the choice of patient care versus staff safety, and staff safety was a priority for me, but a few months into the pandemic, I was really bothered by the poor quality of care we were providing. So we explicitly chose to find ways to use our standard of care evaluations, because we knew we could help, and better exams would prevent more problems. So we were inspired, that last slide was showing some of the inspiration we had from the aerosolizing nature of procedures and the effectiveness of protective barriers. So on this slide, it's showing what a member of our team created. It's a protective barrier, a cube made out of PVC pipes covered in plastic. Next slide, please. Using the FEES box, as we call it, is very effective. And so shown there in the red circle, it prevents the spread of coughing, sneezing, and suctioning. But what was most important is that we trusted this, and it felt freeing and comforting to be able to use it. We had taken back control in a completely helpless situation. Next slide, please. Here we are using the FEES box on a COVID positive patient. And upon reflection, what's interesting is that we had not used this box on other patients with airborne diseases like tuberculosis and RSV. So would we start using this box for other diseases too? Or should we stop using this box altogether? I guess I would say, why take the risk if we know it's protective? Next slide, please. Another form of an ethical dilemma for staff safety was in regards to psychological safety. I really struggled with the day-to-day reassurances for staff. I couldn't say that they would be okay. And so I made a choice to be truthful with them when I could be forthright. Some of them shared that they struggle with compartmentalizing the stressors from working in that environment, going home to babies, children, families, wondering if we would bring COVID home. Next slide, please. This was more than just team bonding. This was a time to debrief, talk about patients, family who had passed away, things that we would have done differently. And so in the middle of this public health crisis, our North Star was being a team and camaraderie. This last slide is showing a slide set from one of our staff meetings. So I try to have monthly check-ins, and I show them vulnerability in myself, such as this is overwhelming and I don't know. And I believe one of the reasons we were able to respond to this public health emergency and improve our care and pivot quickly was because of our collective sense of psychological safety. In conclusion, I just wanted to share this quote. When written in Chinese, the word crisis is composed of two characters. One represents danger and the other represents opportunity. Thank you very much.
Thank you, Jessica. I'm going to move to Dr. David Hammer, who's the interim director of the Center for Emerging Infections at BUMC, professor of medicine, professor of global health. So he's got a very broad perspective. David. Nope. David, are you muted?
Okay, sorry, yeah, I was muted. So I'm going to discuss a somewhat of a different topic, and this is really the challenge of limited treatment options, but also a moving target. Sort of the challenges of deciding what's the best treatment option in a crisis when there's not good data or when data are forthcoming at a rapid pace. Next slide, please. So this, Ravin already showed this, and actually Ravin covered a bunch of stuff that I was thinking about covering. So I'm glad you talked about PPE and some of the other challenges. So I avoided that. But, as this shows, there's just a rapid surge of admissions of patients with COVID. And this led to a lot of challenges because at this point in time, we knew really little about how to treat this disease, at least in terms of antiviral therapy or anti-inflammatory immunosuppressive type drugs. Next slide, please. So infectious disease formed a multidisciplinary working group. Initially, for quite a while, we met 6 days out of 7. We took 1 day off, and we had a number of sub-working groups. Our group included infectious disease, both adult and pediatric, pulmonary critical care. I think Michael was part of this at times. The emergency medicine, general internal medicine, rheumatology, and the pharmacy was involved. Tamar Barlam led the group, and we had a bunch of different working groups, which I won't go through all of those, but I'm going to talk a little bit about the treatment working group. And we had a treatment working group that I was part of, as well as a research group that was trying to basically, as a friend of mine says, it's like sucking on a fire hose. There's just so much information coming out so quickly, but of variable quality. Next, please. So this is just showing one of our meetings. We had Zoom meetings that were quite intense and but well organized and accomplished a lot. Next, please. So as already mentioned, there's a rapid increase in admissions in March and April of 2020. We knew little at this point in time. There's some data coming out from China about different treatment options. And there was a study that came out of Marseille, and actually I know the study authors, and it was really a poor quality study, but it suggested that hydroxychloroquine and azithromycin might be effective. So many people across the world integrated this into their protocols, as did we. Although with time, it was shown that there's really absolutely no benefit of these two drugs. There was very limited supply of remdesivir, and this was known to have some activity early on, and we struggled to get our hands on this. A lot of it was being sort of used in protocols that we initially were not able to be part of, although we pushed and with time became part of some of the multi-site protocols. And then interleukin-6 inhibitors, and there was sort of provocative data from China that these might help, especially in really sick patients, to prevent progression to a inflammatory state. But the problem was there were a limited amount of these available. They're expensive. I think expense wasn't such an issue. It was really the limited amount. So who should they be used in? Next, please. And so this is showing our COVID treatment protocol. I'm not going to go through this all, but a couple of things about this. One is that, as I mentioned, that hydroxychloroquine and azithromycin were part of the initial protocol, whereas corticosteroids were not, because there was a thinking initially that these might worsen or increase risk of progression to severe disease and potentially death. Next, please. So we developed a crowdsourcing approach where we basically, first of all, we looked at the literature and said, IL-6 inhibitors might be useful. So we didn't quite corner the market, but we definitely ordered these and tried to get our hands on a good amount of, especially tocilizumab, with the concerns that there'd be a run across the country on this. And that proved to be true because with time it became hard to access these drugs. We had a team of experienced clinicians on call 24 hours, 7 days a week. And basically, if whoever was in the hospital saw a patient that was starting to deteriorate, they would contact us. Sometimes I remember a couple nights, 1 or 2 in the morning, we'd get a page saying, read your email. And we get up and then we look through all the data, and then we basically have either an email call or email communication or Zoom call, and make a decision about what patient should receive this limited drug, at least drug with limited availability, based on the severity of illness and the likelihood of benefit. And so there's some really challenging ethical decision making in this process. This just sort of goes through the process, and I think actually this just shows the timeline. Next slide, please. And so we developed a protocol, and we identified certain contraindications, for safety purposes. We wanted to make sure we would do no harm, and then a protocol for identifying patients that were most likely to benefit. Next, please. And in the end, we recognized that patients who are just starting to decompensate probably were more likely to benefit than those who are already in the ICU, on a ventilator, and in really a severe state. So this sort of difference between stage 2B and stage 3. And in the end, we found that if you gave this earlier, it helped reduce the risk of progression to severe disease and the risk of death. Next, please. And this was published and eventually. Next, please. So a lot of people are involved in this, but this approach, I think just shows this is just one example of many of the challenges of limited resources. And I think as Ravin mentioned, PPE was another, but the very limited availability of treatment options, of therapeutics that looked like they might have activity, led us to develop this crowdsourcing approach that worked very well, but took a lot of effort to make sure the right patients receive treatment and safely. Next, please. I think that may be it. Yeah. So and then just our group, the infectious disease team, ended up being recognized for this with a Be Exceptional award from BUMC. Thank you.
Thank you, David. You clearly were exceptional. And our last speaker is Jacob Bloom, who's a fourth-year resident in otolaryngology, and obviously. The big part of the staff wasn't just nurses, but it was obviously our residents and fellows that were actually doing lots of the grunt work. Here's Jacob's background. Obviously, both sides of his brain work. He not only got the Golden Humanism Award and Outstanding Otolaryngology Research Award, but I actually looked it up that he played bass in an album that was ranked number 30 by Rolling Stones. So obviously, you're also a wonderful surgeon. Jacob.
Thank you, Dr. Edelstein, and thanks for inviting me to come. It's an honor to be on this panel with all these distinguished people, as Dr. Presenia pointed out. So, yeah, I mean, I just thought I would quickly touch on what it was like to be one of the residents on the ground. Yes, thank you. So I thought I would just quickly talk about my timeline in terms of my education. January of 2015. Was when I started entering medical school, and I went all the way through and graduated in 2019 of June. And then my first day of intern year was in the summer of 2019. And then just about 6 months later was when the first diagnosed case of COVID happened in the US. Then the first case in Mass was in March. And it wasn't until almost a year and a half later that the vaccine became approved and allowed us to have it. So within that time frame, I just put down here, this is a nice chart that shows the new reported cases by day, as well as the deaths by day. And you can see right in that February 2020 spike there was right when I was sort of in the heart of my experience working on the medical floors. So next slide, please. And as part of that response, which these leaders of our hospital have pointed out, I was asked to rotate on not only at the VA as a medical intern, but also in the medical ICU as a medical intern. And obviously I had just sort of gotten comfortable to being a surgical intern when they all came to me and asked me to help out in the medical ICU, which I didn't do a medical ICU rotation. I did a surgical ICU rotation in my medical school. And so I was truly out of my comfort zone. Learning new workflows from people I hadn't met before, and the attendings who I hadn't built relationships with yet. And I guess the things I sort of thought of at the time and still reflect on now is, was I trained for this? Was I ready for this? And the answer was probably no. I mean, I wasn't, but I think, I was scared at the time because we didn't know what the realities of the infectious nature of this disease. And I'm an otherwise pretty healthy guy, but no one knew what the death rate was or the infectious rate was. And I guess I thought about it at the time, and I still think about it now. I went on countless interviews as a hopeful medical student and then as a hopeful resident, talking about my call to medicine and my desire to help patients. And this was it. This was my call. And, I thought if there was a time to stand in there and help out, not just the patients in front of me, but society as a whole, this was my time to contribute in any way I could. And so I didn't know as much about vent settings or D-dimer labs or CBCs as some of the senior residents or chief residents, but I did know a lot about trachs. So I was able to really help the medical ICU team with my knowledge of the types of trachs and what kind of trachs you can use and in what situations can you go from cuff to cuffless and why. And I found that to be really beneficial, and I felt like I really could contribute in that way. And I guess that's my last point, is that you may not feel like you're suited for a team in a certain situation, but I promise you, if you come in with the right attitude and sort of hit it head on, you can definitely contribute. Next slide. And so around March of that year, when I was just finishing up at my VA rotation, where I did pronounce my first patient as a doctor dead deceased from COVID or in general, which had its own host of challenges. And I reminded of one of the talks earlier mentioned he was on the phone with his family saying his final goodbyes on the iPhone, just sort of on FaceTime, which was a terrible thing to face. And I still think about that. But my roommate, who was a medicine resident I went to medical school with, came up to me and said, I can't smell. I don't know what's going on. I can't smell. And this paper here had just been released earlier that month, and I had read it in an otolaryngology journal from one of the Stanford rhinologists about COVID and its lack of smell. And I sort of had a moment where I didn't tell him because I wasn't sure if he could handle that information. Because again, at this point, we didn't know what the course was going to be. And this is something that I'm sure everyone here has struggled with patients, where they ask you, when they tell you something that is going to severely impact their life, and how do you break that news to them? But this was a colleague and a friend, and honestly, a brother of mine who was in the sticks with me. And I told him, I said, listen, I think you should get tested for COVID. And then I thought about my own life and living with him in the same room, in the same place. There was no hotel I could go to or place I could stay. And so I decided to stick it with him. I wore a mask, but I wanted to take care of my friend, and that was just what I had to do. And obviously he just matched in Hem/Onc fellowship today, actually. So congratulations, John Choi. And I guess the last thing I'll say is people aren't statistics. We have all these stats, and, they went over some great numbers today about the things. And I remember sitting in those meetings as a resident, and Dr. Davidoff was talking about the borrowed vents and all that stuff. And it's bringing back all these memories, but each individual person is different. And these statistics basically just help us take care of the comprehensive patient. And how do we deal with these traumas is something that everyone else has described. And for me personally, I have many ways of dealing with the traumas of being a doctor and a resident. But one of my research projects is about anosmia and age and demographics, so that we are able to better counsel our patients when they come to us in our clinic about not being able to smell, and be able to provide them with the best information we can, and sort of help them in the best way we know how. So thank you again for allowing me to contribute.
Thank you, Jacob. And your heartfelt discussion is much appreciated. So I know that we're near the end of our hour, but we do have some time for some questions. I'm going to ask the first question. I was the head of the IRB, which is the Institutional Research Board in my institution, for about 5 years. And I just wanted to say to all of our wonderful speakers, including myself, that we would all be on probation in normal times, because we did novel therapies and novel things without IRB approval. So I'll open that up probably to Dr. Young, the head of the ethics committee, which is, did we do it ethically, and when do we bring back the IRB, and are we required ethically now to take these novel therapies back to the IRB to re-review?
Yeah, thanks for that. That's a great question. I think that at the time, there is the common practice of not necessarily employing practices that are experimental, but that are basically informed by expert opinion. And at that point, I think, to David's point, that we were really, there was nothing, there were no references, there's nothing we could look to. And so we had to really use our group think, which I think was actually fairly effective, to both think about what we know, and then think about the benefit potential, and then also the risk, the harms. And I think most importantly, one of the things that did happen was whenever we did use these therapies, we got to the point where we were really using as much as we could essentially informed consent. So we would tell people, this is what we know, and this is what we think we'd like to do, but it's based on, limited. So we did develop an informed consent process, particularly for IL-6. And I think that is good. As far as what happens afterwards, I think that we definitely did start to pull back on all these kind of just try things. And there was a lot, and in terms of the IRB, the IRB was actually quite active. We were having all these, kind of essentially experimental, if you will, treatments proffered by a lot of different sources, some of them drug companies, but they had to approve it if we were going to use these treatments, and we had to do informed consent. So we did, it was quite active, and there were a number of trials that we engaged in. I don't know if David wants to say anything more, or somebody else.
I would just add that for this interleukin-6 work, we did end up going through having an IRB review of the protocol and the approach that we used. I don't know, I can't remember exactly when that happened, but it was definitely reviewed. And I think, as Michael said, the IRB sort of dropped all routine things pretty much and focused just on COVID-related activities, and they were very busy reviewing those.
Yeah. So I guess what I'd say what was just astounding is, David, I'm sure being part of IRB, like what their kind of historically characteristics of working slow and takes a while. That was not the case. It's like that was the most impressive thing. You'd submit something and it would turn around so fast. I'd never seen the IRB work so fast.
Well, that's a wonderful thing for that BU has one that works that quickly, and you used it. There's another question that came up here. I had alluded, this is for David, Dr. Hammer, I had alluded to your global health. So forgetting the fact that I'm not going to compare the first world with the third world in terms of care of COVID, but we look at some of the articles on Ebola and say, wow, what are they doing as ethically? But did our first world ethics live up to it? Or were we all on the same plane with all the other 70 countries around the world that you go to?
I think we have more resources, and even though those resources were very strained, that I think we put a lot of thought into really careful resource management, as Raven has described, and we did that, with the treatment with the IL-6 inhibitors as I described. So, I think we did better, but we faced the same challenges. I mean, the limited amount of supplies, medications, and resources, including space, to manage severely ill patients, and that led to some tough decisions that are the kinds of decisions that people in low and middle income country healthcare settings face every day.
Yeah, thank you. There's another question here actually for Dr. Davidoff, which is, now that we've lived through this, what would you do differently from an ethical point of view, not from a care point of view, but from an ethical point of view, if anything?
Yeah, I think, Michael talked to some of the collaboration that happened and the benefits of that. I think it took a while to get that going. And I think that looking forward, I would hope that we would share more with the other AMCs in town. This town is very rich with lots of smart people and lots of beds. And I think I would hope that the state would be more helpful in coordinating the efforts, because what Michael describes occurred at the grassroots. He reached out to his colleagues, they then worked through this. So I think just more coordination about where are the resources, what do we need? And then strategic planning about supplies. I think we learned a lot about this and managed to get things, but at times we were getting things that were not appropriate, that were fraudulent, and we learned how to carefully select what we got. So I think we have a much better supply in the back that we can pull from if there's a shortage that would happen tomorrow.
I'll tell you interesting ventilator stories. So after the swine flu, New York State came up with a 99-page document on how to allocate ventilators. Anybody want to venture a guess how long that program lasted? When it was boots on the ground, it lasted about 3 days. Because it was, again, I didn't think it came up well enough with equity or justice. It was poorly managed. So hopefully each state and city will come up with, or nationally come up with a better plan. I know that after swine flu, there were supposed to be ventilators produced in Baltimore that were paid for, and obviously none of them met the standards. So we all have to work a little bit better. Another just brief question, and I know we're at the end of our time period, which was the ethical problems in mandating the COVID vaccine, not in the public. I'm just going to say for the moment, what about mandating it amongst our staff, which worked so well, spent all their time, and then they were told either get vaccinated or lose your job. At least that's what happened here in New York. Was that ethical? Was that correct? Answers, thoughts?
Maybe I'll take a first crack at this. I mean, this is a challenging question, but we went through similar decision making. I ended up working with BU leadership at in the president's office for making similar decision about the whole campus and immunizing campus. And I think at the time when the vaccines first came out, they looked like they would protect against symptomatic infection as well as severe disease and hospitalization. And really to try and reduce transmission, we thought this would be a great tool to try and prevent the spread of the disease. In the end, they don't work so well in that regard, especially as Delta and Omicron came along. But I think from the ethical standpoint of trying to curtail onward spread of the disease and also reduce the severity and the need for hospitalization and high-level ICU care, and I think it makes a lot of sense. At least it made a lot of sense at the time.
I want to comment that I had my team read the vaccine study trials, and we talked about it. And I think that was really helpful. It wasn't an issue on our team. 100% of our staff got the vaccine without issue, and they're also boosted, which isn't required but recommended. But reading the trials was really helpful to help us be more informed, and we were also instrumental in talking to patients about this. We were trying to help a lot of patients in answering their questions. We weren't trying to convince them one way or another, but just answer their questions. So it helped us to be really informed about the facts.
I'll make a comment. So I live in Manhattan in New York City, the communications capital of the United States, if not the world. And I would tell everybody who came into me that we should have a cable TV show just on medicine during COVID. We were all a bit hypochondriacs, but that would have been a good way to actually educate people when you talk about public health. And along the same lines, it said, no, by the way, we need to teach everybody statistics. You can't be an academic without understanding statistics to be able to read the literature. But it's remarkable how the public knowledge of statistics is poor and how to understand why you get vaccinated and the risk-benefit ratios. There are statistical analyses. You don't have to talk about it's because I say so. It's basically the statistics are there. And I think this was a tremendous missed opportunity when people were home not to teach them about statistics. I think we can make a lot of the other parts of people's lives better. But when it comes to medicine, you're not just winging it. Other questions? There's a hand by Dr. Strauss.
Thank you so much. Hi to David from my class and Revan he was behind me at Boston City, and Robert Witzberg was my residency chief. Anyway, I appreciate everything you all have done here, but I have two questions. And if you can only get to one of them, then it's the one that's happening at the present. One was what you all did about patients that were not vaccinated. And I had a terrible time with arguing with myself about whether these people should be treated, on a first come, first served basis if they were keeping, other people out of an ICU. So that was one thing, from their own acuity. And the second thing, which is more concerned with today, is there is so much misinformation out there, including radio hosts. The most recent thing going around is that there are 1 million vaccine deaths. And here we are going into, increased COVID with new variants and people who, need boosters and all of that. So you all may be, you're academics, you're wonderful. You may be insulated from this, but there is a lot of misinformation out there, and it's very difficult to deal with. So thank you.
Yeah, so thank you, Ruth. On the second question, the answer is yes. Data will set us free. It was too bad that most of the statistics were collected state by state. There's great variability as to what was collected. It really, I thought, should have been much better collected by the CDC. I think the head of the CDC lives up near, just outside of Boston. And, ultimately, I think this was a general failure of the federal government, but hopefully as time goes on, we'll be able to collect those statistics.
David, can
yes.
I just respond to the first point about
Sure.
people who didn't get it? Because I think that there was actually amongst some of our ICU providers some intense anger, particularly like kind of at the end of the first surge and beginning of the second surge, about patients that didn't get vaccinated and if they came into the ICU and we were taking care of them. But I think that, kind of thinking from kind of an ethical standpoint, that people all our patients don't do lots of things that they should do, and holding them accountable for it is something that we generally don't do. This is a very kind of discrete and concrete thing in this instance, but broadly speaking, there are people, who have diabetes, who have heart disease, and we don't hold them accountable for the fact that they continue to smoke and such. And in some ways, exactly because of the misinformation, it is hard to kind of, hold somebody accountable for not being vaccinated, and in some ways put them, further back in the line. And I don't think that we can, we are really in a position to do that.
Excellent point.
It's a very good answer. There are also doctors who didn't want to participate, and they all, I think I mentioned that in my chat, we had to deal with them. Somebody from my department said that he broke his finger. Okay, did I really think so? No. So he and I had to have a long-term conversation over a few weeks to get him to come back and cover and do things. People were fearful, and doctors are no different, nurses no different. You'd like to think, as I said, it's our muscle memory, just like Jacob Bloom playing the bass, our muscle memory, it's our brain memory. It's the course I took as a first-year med student at BU on who shall live, the ethics in medicine and how to make good decisions. It was very valuable to me that I could, help a format, make some decisions. I had 152 people in my department. We had 17 meetings. People thought it was very nice. I was able to listen to them. But it was also a way for me to hear the concerns and give one answer so that 151 other people heard the answers if they were feeling it too frightful to ask it. I hope that people in my department realized I would ask one question or two real serious questions per meeting, because I wanted to hear what their answers were, just the same way we saw here the Zoom meetings from the ID department, the meetings with the ICU department, Dr. Davidoff getting all the senior people, because this was a coordinated effort. And it wasn't one person's sense of ethics or the ethics that were in the Principle of Ethics book. There are parts of that book I'd like to rewrite now, Michael. So the fact that it's now 7:14, I want to thank our panel, Dr. Davidoff, Dr. Young, Dr. Bisegna, Dr. Hammer, Dr. Bloom. You're really wonderful, and you each talked on similar but very different subjects. Your stories, I think, were very revealing. Special thanks to Greg Goulon, the chair of my department at BU, and the former chair and former assistant dean, Ken Grunfast, who's been an inspirational force at the medical school on professionalism and ethics. He knows my father, Alan, would have loved the talk tonight and been talking about it for weeks. You were also obviously the inspirational force to pick the people on the panel other than myself. And Ken, I have special thanks. I think you did a wonderful job. Many thanks to Maura Coakley and Nick Sims in the development office, who made tonight's meeting look effortless. It took a lot of effort, and I appreciate that. And to Janine Lipsky, was one of the academic administrators in the Department of Otolaryngology. And obviously, thanks to Dean Antman and the Boston University Chebanian and Avedisian School of Medicine that trained Marcia and me and many of us in this meeting, either as medical students or residents and fellows. And good luck. You have the joy of now using the $100 million that Mr. Avedisian gave to the medical school. And I think you are well trained to find ways to spend it. We hope to see all of you next year. And if you have some good subjects or speakers, please feel free to email me or call me. And I appreciate everybody who came online. Lots of you are doctors, nurses, speech pathologists, friends of BU, friends of some of us and the speakers. But I think you see that the care of COVID wasn't just taking care of patients. It was working as a team. You saw that was a solution that each one of us came up with, and that the ethical dilemmas are very broad, and we only touched on some of them. I think BU should be very thankful to have Dr. Davidoff, Dr. Young, Dr. Bisegna, Dr. Hammer, and obviously Jacob Bloom is one of the residents. I think you all did a wonderful job. So thank you very much. I look forward to seeing you next year, and hopefully you'll participate in our professionalism and ethics lectures. Thank you.